Well, first of all, we need to know what was it that you weren't seeing? You weren't seeing this?
Hey, yeah.
You weren't seeing that because of the teeth?
It was like it was all the way to the bottom teeth, like.
Then their head was tilted too far back.
Okay.
Yeah. So the object of trying to get this done is see the top of your incisors. Top of the incisors. That and your mastoid tip have to be parallel. They have to be in the same line. So you tilt your head until your teeth and the back of your head is in the same line. Okay? If you're too forward, you get the teeth in the way. If it's too far back, you have the occiput in the way. When I say occiput, I say occipital bone. Okay? So they have to be properly aligned. And here's also the key. When you position them, you do it while their mouth is open. Okay? Not while it's closed. Okay? Because when you open up your mouth, everything changes. The alignment changes. So you have to do it while the mouth is open to get that proper alignment. Does that make sense? Okay, don't do it while it's closed. You do it after it's open to align it. Yeah. Now, if you guys have problems doing that, of course, there are some other views that you could have tried. Did you try it?
No, too much radiation. We just
gave up.
Too much radiation.
The tech watching us, she was like, "It's okay. She's a young patient. It was enough." So.
Oh, okay.
But she doesn't have a dentoid.
Yeah, because we had to do a dontoid view when the person had a neck brace on.
Okay.
So they couldn't, go back. So we just angled the tube, that, to a certain point, and to try to get the light. And somehow it turned out fine.
That's called the Fuchs.
Yeah.
Yeah. Yeah. Yeah, it's called the Fuchs method. So you do that without them opening up their mouth. Did you open up their mouth?
He could.
You still could open it.
He could open
Okay.
up. So they just managed to do it.
Oh.
It was students too. It wasn't tech.
Cyrus?
Okay.
Oh, of course. Okay, and you got it.
Yeah.
Okay, good.
Yeah. It was
So that's going to be the fun part of your job, because if it's not textbook, you got to figure it out. Okay, but not at the expense of the patient with your retakes. But I mean, it's a good time to try things. If the textbook doesn't work, try something else. And that's why it's so important that we stress anatomy and understanding the orientation of all the different parts and how to angle, your body and the tube to get that perfect picture. That's where the, creativity comes in. That's why when you guys come in, you're here in the program, yes, we know you're smart, but can you problem solve? Okay? That's where it comes in, is your problem solving skills.
We can create problem, no problem.
Because, what do you guys find out now? Is everything textbook that you do out there? No. Not even, right? Not even. All right, so quick summary for intervertebral foramina. It's going to be a 45-degree obliquity, looking at the side furthest away from the image receptor. And if we're looking at the zygapophyseal joints, it's a lateral. Now, if we're doing a lateral, is it left lateral or right lateral? Left. It's usually left. Okay? Just like a chest x-ray, we do it left. Okay? Oh, there's that guy again.
It was not me making a sound.
Okay.
I think the start point has sound effects now.
All right, guys, be familiar with your landmarks. Okay, I'm just going to do a quick run through here. Be familiar with your landmarks. You already know your landmarks, just review them. Okay? Okay, you got it? Review. I'm not going to spend too much time with this. You guys already know this, just review it. Okay, pathology terms. You guys ready? Yeah. Okay, HMP. That's your bulging disc or your herniated disc. Okay, also known as a slip disc. So again, if the nucleus pulposa protrudes to the annulus, it presses up against the spinal cord, then you can have that pain, you can have that numbness. Now, can you also have protrusion anteriorly? Yeah, you can still have it protruding outwards, but usually don't have those issues. It's usually when it goes towards the spinal cord that you have the issue. But you can have a herniated disc without it causing any problems with your spinal cord. Okay? All right. Clay shoveler's fracture is a type of avulsion fracture. So this is where you have the tendon pulling on any part of the bone. This is specific to the spinous process. It pulls on it and causes a fracture. It's a type of avulsion fracture. And it's called a clay shoveler's because, you guys shovel clay?
Every day.
Right?
We shower clay every
I guess
day.
back in the day they did a lot, but it was associated with those who shoveled clay. Yeah, very strenuous work to cause that type of fracture. Compression fracture, where the body becomes wedge-shaped. So this is a compression fracture of what? What is it a
Body.
compression fracture of?
Body.
The vertebral body, okay? So due to trauma, osteoporosis, or some type of metastatic disease, you see this it's very common in osteoporotic patients where they have the compression of the vertebral body causing that wedge shape, and so that's why they're humpback. Okay, because that wedge fracture that occurs, it usually involves more than one vertebral body in osteoporosis. Okay. Teardrop burst fracture. Teardrop burst fracture is caused by severe hyperflexion. Which way? Head back or head forward?
Forward.
Extension, so it's forward. So this is flexion. So extreme hyperflexion. The vertebral body is comminuted with probable damage to the spinal cord, referring to this. So can you have a cervical fracture without it causing problems to your spinal cord? Happens all the time. Okay? So if the fracture is anterior, not a big deal, but if the fracture is towards the back, okay, now you may have some issues. Okay, but you can have neck fractures without it being such a bad thing. Sherman's disease. This is where you have, it's very kyphotic, so normal round back in the upper spine called kyphosis is increased. Most people with Sherman's disease will have an increased round back or hunchback, but no pain. I had an uncle like that. It was weird. Yeah, he had an extreme humpback like that. And as a kid, yeah, you stare a lot, right? He's still alive. Which is scary.
Do you still stare?
Huh?
Do you still
I
stare?
saw him. He looks exactly like he did when I was 5 years old. It's like he didn't age.
Wow.
Yeah. So that's what I mean. It's scary because he still looks the same age. With a humpback.
Humbrace.
Yeah. Spondylitis just means inflammation of the intervertebral joints. That's all it is. Okay? Inflammation. Ankylosing spondylitis is a little bit more involved. So it's an inflammatory condition, but what happens here is due to the inflammation, it causes the bones to touch, and eventually when the bones are in this position for a long period of time, they start to fuse. Okay? So inflammatory condition where the spines become rigid and then eventually becomes fused. Highlight this area, it begins at the sacrum and up towards the spine. So it usually occurs at the lower lumbar region. Okay, this is more common in the lower lumbar region. Okay. So when we're looking at this x-ray here, does it look unusual to you? Well, first of all, do you see any spaces between the vertebrae? Okay. Not only do you not see any spaces,
Between processes, no spaces, like one long
it's
crest.
just one long, so everything is fused. But what else is also happening here? Is it a little bit too white to be bone? It's due to the fusion. So there's some overdevelopment of bone as well. Because bone, it's not this type of white. It should be something like this. It's a little bit on the light side, but this is very white. It's very solid, showing that there is increased bone density. Okay, all right. Hangman's fracture. Fracture of the pedicles usually on C2. Fracture of the pedicles usually on C2. Now, again, remember what I said. You can have a fracture like that and still survive. Okay? So if it involves a spinal cord, now you're dead. Okay? But you can have a fracture like this and still survive. What's it called? The hangman's fracture. Exactly. All right. Jefferson's fracture. Anterior and posterior arches of C1 are fractured, caused by landing hard on your feet or on your head. Guess where this fracture is most common?
I'll say jumpers.
Huh?
Jumpers.
Kids.
Usually common in beach resorts.
Diving in a pool.
Diving into a pool, or diving into the beach, not knowing how shallow the water is. You know, you're running towards the waves, you dive in, and you hit the bottom of the floor, the beach floor. Okay? This is very common in Hawaii. Okay, Jefferson's. He doesn't sound Hawaiian. Okay, scoliosis. Scoliosis involves it's a extreme lateral curvature of the thoracic and lumbar column. So curvature is, if it's less than 10 degrees, that's normal. And then you have your different types. If it's greater than 10, okay, but less than 20, it's mild. Moderate is 25 to 45 degrees, and then greater than 45 degrees is very severe. It may require some type of surgical correction. But it's not just a curve now, because what's going to happen here is the more extreme the curve, and it involves the lumbar area, is going to also cause a pelvic tilt, okay, which can cause the individual to have a limp when they walk. Okay, so you look at this one, you can see also already that one of their pelvis is higher than the other. One wing is higher than the other. Have you guys done a scoliosis series at your hospital yet?
Yeah.
Are they pretty extreme?
We did very, very like mild one almost.
Have you ever seen an X-ray of someone who had the rods put in? Oh, that's crazy. And when you look at their back, it looks like a zipper. Because they cut all the way through the back. You see the different sutures. They look like, yeah, just look like a zipper. I'll have to find one and show you guys. It's pretty cool. Spina bifida is where the posterior vertebrae fails to form, exposing the spinal cord. Okay. So here's an ultrasound. You can see the vertebrae here, but it doesn't have the posterior part of the vertebrae here exposing the spinal cord. Okay, spondylolisthesis. Spondylolisthesis. Spondylolisthesis is a forward movement of one vertebrae in relation to another, may be caused by the development defect of the laminae. This is the laminae back here, or the pedicles up here. Okay, so due to the lack of development, there's a separation between adjacent vertebrae. Okay. Spondylosis. God, they all sound the same, huh? Spondylosis. Spondylosis is a broad term meaning degeneration of the spinal column. In the more narrow sense, it refers to the spinal osteoarthritis, the age-related wear and tear of the spinal column. Yeah, sometimes when you look at this, it looks like there is some fracture going on there. That's basically a sclerotic type of process. Sclerotic just means change in it becoming more hard, more dense. And it also changes the shape of the body. But this isn't, when you see this, it's not a fracture, it's just an aging process. chance fracture caused by hyperflexion. Is that? That's also chin down, right? Okay. But this is more on the lumbar region. Caused by hyperflexion, fracture through vertebral body and posterior elements. Vertebral body and posterior elements. Odontoid fracture. I've never seen one like this. The only fracture that I've seen odontoid is at the tip. I've never seen one down here at the base, but it's always been at the tip.
How would you break that?
Just hyperflexion or hyperrotation. Yeah. All right, you guys can go through this on your own. Did Miss describe myelogram with you guys yet? Have you guys ever seen a myelogram? Okay, what's the purpose of the myelogram? I'll just do this real quick because you're going to see this out there in the field. So what's the purpose of the myelogram? Okay, so a myelogram is where we introduce contrast agent. The doctor is going to access the spinal cord, okay, but they're not going through the spinal cord, they're actually going on the outside, the sheath, the covering of the spinal cord, the protective covering, and they are going to inject contrast on that sheath to outline the different, you can see the roots, the nerve roots coming out of the spinal cord. This is usually done to assess, why is it that they're having pain in the lower leg? Why is it they're having numbness? Usually done as a lumbar myelogram. Thoracic myelogram is rarely ever done, and sometimes they do cervical myelograms. Now the problem with cervical myelograms is you have your spinal cord there, and if they nick your cord, it can cause paralysis. So myelograms are more common in the lumbar region, and if you remember first slide, the spinal cord runs from the medulla oblongata to the level of L1, L2. So past L2, that's where they put the spinal needle in there. Okay, past the medullaris, the conus medullaris, where it starts to flare and taper out. So they put the spinal needle there. Now, before they do that, before they put contrast in, they're going to take some spinal fluid out. Okay, so again, for those of you guys who haven't seen one before, they're going to take spinal fluid out. Okay, because if you kept the spinal fluid in there and you put contrast, it's over volumized. There's too much in there, so we got to allow for space. So it's two purpose: allow for contrast to be administered, and also to send the spinal fluid to pathology, just to see if there's any type of disease going on. Okay, but that's what they do. So it's broken down to two different processes. We'll inject contrast, take some pictures, and then they're going to go where? Or CT. Yeah, MRI or CT. Yes. Okay, because they can get a better evaluation of the spinal cord that has been outlined with contrast. So that's the myelogram. Okay. Any questions about this? So how many of you guys have seen one? They're pretty cool, right? Okay, nuclear medicine, bone densitometry, you guys can look over this. Okay, you guys want to go on break, or you guys want me to get started on positioning?
Go for it.
Go for it.
Go for it, okay. You guys ready?
Woo!
Yeah.
All right. Did I tell you guys you're my favorite class?
Aww.
Aw,
You know that, right?
we love you too.
Is that on recording?
Is that on recording? Yeah, and you can play it back. You guys are my favorite class.
They want to play it to all the other classes.
And I tell because Mr. B too, I tell him, I said, I used to like your class. This class used to be my favorite class. I said, this is classic. I said, this class outdid you guys.
Aww.
He's like, yeah, I agree. He goes, I agree.
You're so right. So.
because his class was very tight. They did a lot of stuff together. And so I'm seeing some of the same things that I saw in his class, but you guys seem to be a little more cohesive, more fun. You laugh more at my jokes.
You should see us after hours at the campus.
I know, I'd
Yeah.
love to, but
Should join one time.
just take pictures.
Picture wouldn't do it. Video should
I know.
be fine.
He regrets it.
All right, so let's go ahead and talk about positions. Okay, so cervical spine position consideration. So AP versus PA. The consideration for AP versus PA is, if you look, we're shooting the neck. All right, what's around the neck area? The thyroid, okay? So we try to avoid doing this because it's direct exposure to the thyroid versus this is PA. This is less exposure to the thyroid. But again, the type of X-ray equipment that we use nowadays, especially with digital and computerized radiology, the amount of dose that the patient that they're receiving is much more insignificant than it was with film radiography. So I think this was more of a concern when we used film, but now with digital imaging, it's gotten a little bit better. But that is why we try to decide which is better, AP or PA. And you do whatever it is that your techs are showing you how to do it. Okay? Another consideration, look at where the neck is in location to the image receptor.
Distance.
Okay, so we have some what?
OID.
We have some OID. So if we have increased OID, what does that mean radiographically?
More mass.
Okay, so we got.
Oh, we need
so
to-
I'm seeing this. So you're getting magnification. So what happens when you get magnification? What happens to details?
Loss.
Less detail, less resolution. So how do we compensate for that increased OID?
Increase SID.
Increase SID. So we generally do C-spine X-rays between 60 to 72 inches. 72 inches seems to be the norm. Now, if I'm doing AP, do you need 72 inches? What do you need?
40.
40 inches. Okay? But now once I do oblique, look what happened to my neck. Once I do lateral, look what happened to my neck. But in AP, it's close to the image receptor. Now, with that said, because we do all the other X-rays at 72 inches, the AP is usually done at 72 inches for the sake of working smarter, not harder, keeping everything at the same distance. Okay? But you should be doing it at 40 inches. All right? So I'm telling you what you should do, but I'm also telling you what you will see out there. Okay? All right. Small focal spot size. Why do we want small focal spot? Low
Detail.
We want detail. Okay. All right. Medium KV about 70 to 80, and then shielding. I don't know what that means. You're still going to shield the groin area, even though you're shooting the neck. But I think this is referring to maybe the breast tissue or maybe well, you can't shield the thyroid. So I'm not quite sure what this means. So we'll leave that alone. Okay, so the routine then is it's an AP axial, bilateral obliques, one lateral, and then we'll do an open mouth. And what's the open mouth for? Periodontoid. Okay, and then we'll talk about the alternate projections here. So the first one here, see that? First one here is the AP open mouth. This is also done at 40 inches, okay? So it doesn't say it up here, but this should be done at 40 inches. So the AP open mouth is to evaluate the dens of C2 and the joint, the zygapophyseal joint between C1 and C2. So the upper incisors and the base of the skull, that's usually the mastoid tips down here, has to be in alignment. Okay? If you're getting teeth in the way of your radiograph, that means the mouth wasn't open enough or the chin was down. And if you're in the occiput, if this is getting in the view, that means you have too much head extension. Okay? So You position them while their mouth is open, not when it's closed. Position them while their mouth is open. Okay. By the way, there's no talk of lines in here, but if we were to talk about lines, other than this upper incisor and base of the skull, what else should we consider when positioning our patient to make sure there's no rotation?
Mid-sagittal plane.
Mid-sagittal plane, right? Mid-sagittal plane is going to be perpendicular with the image receptor. So we place them on the table or on the wall. You need to make sure there's no rotation of the head. Okay, straightforward. So we're going to have them. Oh, firstly, do we need to get anything out of their mouth?
Dentures.
Listen, if they have dentures and they can remove their teeth, they don't even have to open their mouth.
But isn't it easier than keep the dentures and just open the mouth?
Yeah, you can shoot right through the gums.
Oh my God.
Yeah, whenever I had like an elderly patient that removed their dentures, I was like, oh, thank you. It's like easy, okay, because I don't have to shoot through teeth. So yeah, if they have any prostheses that they can remove, have them remove it. Okay? All right. Have them hold their breath. So we have the dents. We have the zygopophyseal joints between C2 and C1 is demonstrated. Okay. Upper incisors superimposing the base of the skull. No rotation is determined by equal distance from lateral masses of C1 to the condyles of the mandible. Equal distance of spinous process of C2 to the condyles of the mandible. Okay, any questions? Okay. Open mouth for the dens. And also to look at the articulation between C1 and C2. Okay, AP axial. AP axial. Why do we have an axial? Why do we have an angle on our beam when we're doing an AP?
Want to shift some structures.
Look at the neck. Is the neck straight? It's curved. Okay, so we're going to try to compensate for that curve by giving it an angle. So when positioning your patient, you're going to try to match the angle. So again, the angle that we're looking at here is from the mental point to the base of the skull. Okay, that's what we're going to use to determine our angle of our beam. Because your angle of your beam says anywhere between 15 to 20 degrees. Okay? So we're going to look at this imaginary line from here to here, and we're going to match it. And that's why it says 15 to 20. Whatever that angle is, we're going to match it. Okay? So central ray, 15 to 20 degrees cephalad, centered at the upper thyroid cartilage. Do you guys know what the thyroid cartilage is? The Adam's apple, so right above that. We're going to ask our patient to hold their breath and avoid swallowing. Now, I always find this out. When you tell them not to do something, what are they going to do?
They want to do
They're
it.
going to do it. So I just tell them to hold their breath. Okay? This is just my thing, okay? But in a test question, what are you going to tell your patient to do? Hold your breath and don't swallow. Okay. All right. Now, can we also do this PA? Okay. I don't know why you would do a PA, but let's just say we did a PA. Okay. What are you gonna do now with your angle?
Caudal.
It's gonna go the other way. Okay. I want you guys to always think of options. Remember, you're a learning textbook, but your patients are not gonna be textbook. Okay. So think of alternatives. Is this on your slide? You have this, right? Okay. Just popped up. Oh, you have this too? That just popped up. Occlusal plane and mesotip superimposed. Okay. Where are these lines coming from? Okay. Now, when we do an AP axial, we're not seeing the entire C-spine. Okay? We're missing C1 and C2. That is why we do this. Okay? When you're doing an AP C-spine axial, you're not seeing C1 and C2. So an AP axial is good for evaluating C3 to T1. Okay? Why doesn't it say to C7? We need to see the next set of vertebrae. So although we're doing a neck, we still need to see T1. Okay? Remember, it's like when we were doing the extremities. We shot let's say we shot a finger, but we needed to see the adjacent, adjacent structures. So we need to also see the adjacent structures. Okay? All right. So C3 to T1. Spinous process is equidistant with no lateral borders of the spine. The intervertebral disc should be open with the angulation. If you went straight on, you're not going to see those spaces. So you got to have an angulation, about 15 to 20 degrees. Okay? So hold your breath. Don't swallow. Okay, any questions on this one? All right, you guys are awesome. So this is what we talked about earlier. Why do we do this? Because there's less radiation if you do it in this position. Okay. So let's talk about now the obliques. In the obliques, you're going to rotate your. On the next slide. Yeah. You're going to rotate your patient 45 degrees. So shoulders 45 degrees. 45 degrees. Okay. But this is what you're also going to do. You're going to put them 45 degrees. You're also going to put their head in a lateral position. Okay? Why am I doing that?
Chin.
I'm trying to get rid of this area. Okay, so I'm trying to get rid of the angles of my jaw, my gonian. So when you place them in a 45-degree angle, you're also going to have them look laterally. 45 and have them look laterally. This is now where you're going to increase your distance to 72 inches because of the increased OID. And then you're just going to have them hold their breath. Okay, hold still, don't move. Hold still, don't move. So, in this position, first of all, what position are they in? This one. RAO. So, which intervertebral foramina are we evaluating?
Right.
The right side. How about that one? What position is that first? LPO. What are we evaluating?
Right side.
Also the right side. Okay? All right, you guys got it. Now, we didn't talk about collimation here. So if you're going to I'm going to go back to the AP. Using a 10 by 12. Starting off with a 10 by 12 field. Are you going to keep it wide open? Or should we bring it in? You're going to bring it in. Okay, bring it in. Same thing here, when you're doing this odontoid, I'm sorry guys, I'm going to go back over here. Look at the collimation. It's basically a 3 by 3. Okay, 3 by 3, no more than that. 3 by 3, 4 by 4. It's not in your book. It's not on the slides. It's Dr. F. That's right. 3 by 3 or 4 by 4. You don't need a lot of collimation. You just collimate to this area of interest. So collimate to the area of interest. That's all you need to do. You don't need the entire image receptor. Collimate to the area of interest. Okay? All right. So for the oblique, we're looking at the intervertebral foramina of C3 to C7. Cervical pedicles are well demonstrated, and base of skull not superimposed over C1. That's why we also have you turn your head a little bit. Mandible not superimposed over the spine when head rotated in a lateral position. Okay. question. Good. Okay, lateral position non-trauma. Also done at 72 inches. I gave you guys a preview earlier. So 72 inches, left lateral. Okay. Chin slightly forward. We're going to make an exposure on expiration to help relax the shoulders. What we also tell our patients to do, and this is what I do, is when I'm positioning them for the lateral, I've got my patient here and I'm positioning them, I also do this. I go, relax. I'm pressing down on their shoulders. I say, relax. Okay? So don't just tell them to relax. Press on their shoulders to know what you mean when you say relax. Okay? So press the shoulders down a little bit. Just relax. And they go from this to, okay? Their whole posture changes. Okay? So we want to get those shoulders out of the way. Central ray is at the level of C4. Again, that's at the thyroid region. Okay? Having them look straight, shoulders relaxed, calling me to the area of interest. Take a deep breath in, blow it out. Hold it, hold it, hold it, and make your exposure. Okay? So, hopefully we can see C1 all the way down to, keep going, to T1. You want to see T1. Okay? So it demonstrates C1 to C7, but we want to see T1. Again, we want to see the relationship with the thoracic spine. Okay? The rami of the mandible is not superimposed over C1. That's why when we do a lateral, we have them kind of put their chin forward just a little bit. You guys see what I did? Chin forward just a little bit. Because we don't want this in here.
We cannot see T1 in that, right? We can't do so.
It's down here. Can't see it. So this is not really a good example of what is a good one, because we need to see T1. Okay. So what is the whole purpose of doing a lateral? What are we evaluating here?
Foraminal.
No, that was the oblique. This is the lateral now. We're looking at the zygohypophyseal joints.
And also intervertebral like spaces too?
Yes, and also you're talking about this. Yeah, the spaces here too. Very good. All right. Now, let's talk about trauma real quick. When you get a patient from the emergency room, they get in a car accident, the doctor orders multiple x-rays. So it could be a hip, it can be a foot, okay, and then you also have the neck. So you get a trauma patient from the emergency room with all those different orders. Which one are you going to do first?
Neck. C-spine.
Which neck?
Lateral.
Lateral neck. So no matter what it is that you get from the emergency room, if you have a series of procedures that you need to do, the very first x-ray that you're going to do is a lateral C-spine. Because that is the first thing that we need to clear to make sure that we can